Hey, good morning. Welcome this bright and early morning. We're excited to have you here, and in particular, we're going to be honoring Women's History Month. And as part of that, I'm delighted to welcome you to this morning's special grand rounds featuring three outstanding women researchers from the Division of Pain Medicine. But I will share with you a little secret. These are not the best women researchers in our division. No. They're the best researchers in our division. They just happen to be women. They're some of the best researchers on this planet, and they are going to be presenting to you today a unique perspective of science and treatment of pain that's going to cross basic laboratory research to clinical innovations to cutting-edge behavioral therapies. And their work not only advances our understanding of the mechanisms of pain, but also advances patient care for those suffering from pain. And they exemplify the vital contributions to women in academic medicine. The first speaker is going to be Dr. Vivianne Tawfik, whose slides I have keyed up here. She's an associate professor, and she is the vice chair for research in our department in basic sciences. She leads a clinically informed academic basic lab program that's investigating immune cells, microglia, astrocytes, and their role in the spinal cord and in the brain and how it drives the persistence, the maintenance, and the alleviation of pain. And she's been translating that into new and innovative therapies for chronic pain. Our next speaker will be Dr. Jennifer Ha. She's an associate professor within our division. She leads multiple NIH-funded grants that explore the intersection of mood, pain, and medication use, particularly focusing on opioid use after surgery. She's also running a large NIH multi-site study on peripheral nerve stimulation and pain, which I think she'll touch on this morning. Last year, she was the top NIH-funded anesthesiologist on the planet. She also co-directs the Stanford Pelvic Pain Program, applying her expertise to help both men and women who are suffering from complex pelvic pain conditions. And rounding things out will be Dr. Beth Darnell, a professor and director of the Stanford Pain Research Innovation Lab. She is a leading expert in behavioral therapies directed for pain. She's pioneered a brief skills-based treatment, empowered relief, that teaches patients how to self-regulate pain to reduce reliance on medications. That treatment is referred to as empowered relief. It's been implemented internationally in the perioperative and chronic pain populations, demonstrating the power of behavioral approaches to lessen suffering and improve function. So please join me in welcoming Drs. Tawfik, Ha, and Darnell. We look forward to learning more about their research. And let's get things kicked off with Dr. Tawfik. The floor is yours.
Right. Great. Well, good morning. Thanks for being here, and thanks for being on Zoom for those who are not here in person. And thank you, Sean, for the invitation to present. So I highlighted on this slide right away Lauren Donovan, who's a senior research scientist in my lab, who's really been my partner in this project that I'm going to speak about this morning. And I'll mention other people in my lab who've also contributed to this work. So since I'm starting off, I'm kicking off the morning, I always like to talk about pain in general. And obviously, as an audience of anesthesiologists, I think we all know that chronic pain is a major clinical problem. When I started working in the pain clinic as a medical student, what really struck me, however, is just how many people suffered from chronic pain at such a high cost personally and to society. The other thing that struck me as a basic scientist who was very interested in the mechanisms of chronic pain was that we didn't necessarily understand the mechanism of an individual's pain. They would come in maybe with fibromyalgia or with back pain or with migraine. And with rare exception, we would sort of treat them very similarly. I used to joke at Dartmouth that Mondays, everybody got gabapentin, Tuesdays were TCAs, and on and on. So when I was thinking about what I was going to be doing for my own research and my own career, I was really interested in understanding the mechanisms underlying various forms of chronic pain so that we can inform treatment better. And the reason it's so difficult to figure that out is because there's so many different mechanisms that contribute to different types of chronic pain in different ways. And this is an example simply of just an injury to the hand or to the limb. And even just with this, barely representing a fraction of the mechanisms that may be contributing. There's peripheral inflammation. There are sympathetic nerves that can be involved with pain. There's the way that our brain interprets the pain. And we'll hear a lot about how we can, take advantage of that top-down organization to improve pain. So there's all these different places where pain is active. And I've spent the better part of 20 years now studying the central nervous system, in particular these cells, astrocytes and microglia in the spinal cord, and how they contribute to chronic pain through the release of inflammatory factors in this kind of pro-inflammatory manner. So I was very excited about glia. Anyone who knows anything about my research, it's like Viv glia pain. And I was really excited about studying glia when I started my own lab. Unfortunately, my friends, such as Sean Mackey, published a clinical paper just when I was about to start my lab showing that glial modulators don't help pain. And that was really disappointing because I thought, wow, I spent all this time trying to study glia. And then this clinical study, which is way more, foundational than what I'm doing in the lab, because that really translates and tells us what's going to happen in humans, showed that there were glial modulators that didn't help pain. So I really started to think about how was I going to use that information to really inform my own work in my own lab. So I came up with this term. I'm pretty sure I came up with it. But anyway, for the purposes of Stanford, we'll say I came up with it. Clinically informed basic science. And it's really using what we see in the clinic, using the types of studies that clinical researchers who you'll hear from this morning, the type of work that they're doing to inform what we do in the lab, so we can really ask the right questions in the right way to then translate back to the clinic more efficiently and effectively. Because my goal is to help humans suffering from pain, not necessarily mice suffering from pain. So one of these clinical observations that we've made, I'll focus on this morning, and it's a really new area of research for my lab. So it's the observation that aging is a major risk factor for chronic pain. So greater than 50% of adults over the age of 65 suffer from chronic pain. And that's just at one site. There are many older adults who suffer from multi-site chronic pain. What we really don't understand is this relationship between aging and pain and the mechanisms that might underlie such a relationship. We know a lot about aging, however, especially at Stanford. There's really some giants in the field of aging. And one thing that seems to be common to many different types of insults, including aging, is this concept of cellular senescence. And this is a programmed response to stress and aging. So senescence can be triggered by many different factors, cell cycle related factors such as developmental cues, tissue damage. Oxidative stress is a huge one. And you can imagine that as time goes on and you age, these are all things that accumulate in cells. Senescence is very specifically defined. It's arrest of cell division, resistance to apoptosis, and expression of something we call SASP, senescence-associated secretory phenotype, which is really just a fancy way of saying inflammatory cytokines and chemokines. And so this sort of three-way definition of senescence is really important as we sort of think about what these cells might do and actually some of the problematic things that they might do. And the way that they do this is through the expression of very specific molecules, including P21 and P16, which I'll come back to, which are basically cycle arrest. They cause cell cycle arrest. And with cell cycle arrest, the cell can now go into what we sort of consider like a zombie state, where it doesn't die, but it's now spewing out inflammation or inflammatory cytokines and chemokines mediated through NF-kappa B. So this concept in aging is really important. And we know that the accumulation of senescent cells in various age-related disorders actually is very problematic. And there's a lot of work, especially in cancer and in diabetes and fibrotic diseases, targeting these senescent cells. So we were interested in understanding if some of this relationship between age and pain could be mediated through senescent cells. There was a little bit of data suggesting that neurons in the brain can exhibit the senescent phenotype, but we really didn't understand how that affects the pain circuit. So we had this hypothesis that senescent cells would exist in the pain circuit, and that's really from the periphery to the central nervous system, that they would accumulate after nerve injury or peripheral injury, which is a model of pain in the lab, and that they would contribute to pain through the release of these inflammatory cytokines and chemokines. So of course, I told you at the beginning, my lab loves glia. And so when we first initiated this project and Lauren joined my lab as a postdoc, I said to her, okay, go do this pain model, and then let's look in the spinal cord dorsal horn, which is where we focus all of our work, and look to see if microglial cells exhibit these senescent markers. And just so you know, these are microglia in yellow, sort of around the border, and astrocytes in pink. So we were really interested in looking at these cells. And so I said, go look for markers of senescence in the spinal cord dorsal horn. And she didn't see anything. And this is where it's really important to hire people who are smarter than you. So then Lauren said, well, I don't see anything in the spinal cord dorsal horn, but what if I look in the dorsal root ganglia, which you may remember from medical school is where the primary afferent neuron cell bodies reside. And that's a really important site for that initial stimulus getting transmitted from the periphery to the central nervous system. So as I'll tell you in the next few slides, not every story is a glial story. So my lab that is really a neuroscience lab that never studied neurons has now developed a whole new project looking at neurons. So, we can always adapt. So what Lauren found was actually really interesting, and I think a really exciting novel area for discovery in the pain field. So what we're looking at here is a micrograph of the dorsal horn of the spine, of the dorsal root ganglia. And you can see, and you'll see better in the next slide, but the little blue spots. And there's an increase in the little blue spots. And those little blue spots are expression of something called SA beta gal, which is a marker of senescence. And we can see that in young, which are about 10 to 20 week old mice, compared to aged mice, which are the equivalent about mid 60s adults and humans, have a significant increase in the amount of this SA beta gal expressed in the dorsal root ganglia. And there's Lauren again. So then she went on to do a series of different stains to look at some of these specific markers of senescence, P21 and P16, as well as one example of a SASP factor, one of these pro-inflammatory cytokines, IL-6. And in every instance, she was able to show that there were increases in these markers in the dorsal root ganglia in very specific sensory nerves. She then performed an experiment looking at spared nerve injury, which is a very often used model of chronic pain, a neuropathic model, where we cut 2 branches of the sciatic and leave the sural nerve spared. It produces a very specific and long-lasting pain in the outside of the paw in mice that we can test through applying filaments to the paw. And so then she looked at various time points after this nerve injury, and she still saw in young mice that there was an increase in the expression of these markers, P16 and P21. And that was even stronger, more enhanced when we looked at aged mice after this injury. So what we were seeing was the accumulation of senescent neurons with age, and then even more accumulation of senescent neurons when we combined age with a pain model. So we were very lucky after that to have a postdoc who's a very talented electrophysiologist. Chelsea Brewer joined my lab in collaboration with Julie Cower's mentorship from the Department of Psychiatry. And what we were really interested in understanding wasn't just, well, okay, these neurons express markers that make them senescent, but what does that mean for pain? And one aspect of pain that's very important is how the neurons transmit information. And if they become hyperexcitable, that actually is a marker of pain sensation that gets transmitted, again, from the periphery to the central nervous system. And so what Chelsea did was she went in and specifically patched neurons that were senescent, P16 expressing or others, and then looked at the characteristics of their firing rates. And then after that, she actually was able to do single cell PCR to look at what exactly that cell was expressing and make sure, confirm that it was P16 or P21 expressing. So she took a bunch of different measurements, and then she did a unsupervised clustering of all of these cells that she recorded from. She recorded from about 80 cells from young and aged mice, which as far as we know, nobody has managed to do that. It's very hard to do these experiments, especially from aged GRG, because the cells die very, very quickly. And so what she did was she put those 82 neurons by all of their characteristics in this kind of plot. And what we found was that this group number 5 is where we found all of the high firing neurons and all of the P16 expressing neurons. So all that to say that the senescent neurons were the ones that were the most hyperexcitable and seemed to be contributing to that sensitization to pain. So then we went on to see if we were able to clear these senescent neurons, would that change the behavior of the mice? Would that change the way that they responded to stimuli? And so we designed this experiment where we performed that nerve injury. And then many weeks later, because we're really interested in treating existing pain, many weeks later, we treated with a medication called a senolytic, which had been used in the cancer field to clear senescent cells. And there's a lot of different senolytics out there. If you Google senolytics, you'll get something like this, where, there's all these different mechanisms that they can use, but we picked one called ABT263 because the mechanism of that particular senolytic was consistent with the cell type we were trying to target. So that I'll move on from there quickly, so you don't fall asleep. So the first thing we did was just confirm that after treatment with ABT263, we did indeed get apoptosis of senescent cells, which we did. And that was shown by increases in cleaved caspase-3, which is a marker of apoptosis. And then we did a testing for nociception or pain, where we poke the paw. And what we saw in the aged mice is when we treated with the senolytic, they had less sensitivity to being poked, and they also put more weight on their injured paw. So as in humans, if they have an injury, they don't bear weight on that side. And what we were able to see is that they normalized the way that the weight was being distributed between the two sides. So now, as I mentioned, we're not interested in curing mouse pain, we're interested in human pain. And so in collaboration with Donor Network West, which is a donor procurement organization many of you are probably familiar with because they're the ones who you work with for your transplants. But some patients also allow procurement for research. And so Donor Network West will give us a call, and once the procurement's done for transplantable organs, we actually go in and we procure our own DRG and spinal cords for research. And so what we were able to show was that when we procured DRG from both young and aged donors, that there was an increase in P21 and P16 with age. We can't necessarily say that those patients had pain, but because obviously they died of other causes. But we do see, at least with age, that there's an increase in the expression of those markers. And importantly, that there's also an increase in these SAS factors or IL-6. And so we can see here the distribution of that in aged humans, we see increased IL-6, but also increased IL-6 in senescent cells that are expressing P21 and P16. So I ran through a lot of things, but hopefully I've at least piqued your interest in the concept of senescent neurons, and you're maybe wondering how many senescent neurons you have yourself. So I do think that these are potentially a novel target for pain. We think that they accumulate with age and after injury, and maybe even more so in the combination. They can release cytokines and chemokines that can sensitize neurons to pain. And that if we are able to mitigate that, either through targeted action on the neurons themselves or through decreasing some of this inflammation, we can really start to think about mechanism-based treatment for the treatment of chronic pain. So with that, I will thank everyone who participated. I tried to highlight the major players, especially Lauren Donovan, Chelsea Brewer, and then many people have contributed to this project over time. There's always a group of undergrads and pre-meds and pre-grad students coming through the lab. And as Sean said, this is Women's History Month. So, I mean, someone told me I need more diversity in my lab, but I mean, what can you do? So now we love glia and neurons. I hope you do too. And I think, pass it on to Jen now. Thank you very much.
We're gonna save the questions until the end. We'll do a panel session.
All right, so that was a great introduction to chronic neuropathic pain from Dr. Tawfik. And now we're going to swing over to the clinical side, and I'm going to run through peripheral nerve stimulation for the treatment of chronic neuropathic pain. I wanted to give you a wider lens on electrical nerve stimulation and give you kind of the state of the science of the medical uses of electrical stimulation. This review looked at publications over the last 20 years. There's been about 700, and I'll give you the main research themes, which we'll briefly go over, which are peripheral nerve regeneration, different materials for nerve injury repair, restoration of sensory function, and the thing that we're most interested in, which is the treatment of neuropathic pain. So peripheral nerve regeneration, the concept has been around for quite some time. What we see is that brief electrical stimulation actually promotes axonal regeneration after peripheral nerve transection or perhaps like a nerve repair surgery. This increases cyclic AMP, upregulates certain receptors. We see in human clinical trials that there is a demonstrated improvement in axonal regeneration after ulnar nerve injury, as well as median nerve stimulation after carpal tunnel release. This is usually in the form of an hour of electrical stimulation after the surgery takes place. The diagram on the right kind of shows you how electrical stimulation can augment that axonal regeneration. It improves the cell's autonomous response to axonal injury. It also promotes neurotrophin release. Also in later stages of regeneration, promoting motor axonal regeneration, and ultimately organizing the reinnervation of the axon and preventing the end organ atrophy. So very interesting stuff. In terms of neural repair materials, what I think is really interesting is this concept of wireless bioresorbable electrical stimulation systems. This would reduce the risk of many different complications related to our permanent implant techniques that we currently have access to, especially with infection, seroma, the need to revise the implant itself. There's different types of neural scaffolds in development with different electrical connectivity. And just to give it a little bit more of a tangible picture here in terms of neural repair materials, this is just one concept. This is developed in a preclinical model. There is a PLGA cuff. You can see the wire attached to a receiver antenna. And this is all implanted into the animal model. And then in the diagram below, you can see from day 0 to day 25, this whole system slowly gets resorbed by the body. So how fantastic is that if we would be able to implant a device that slowly resorbs over time? And Dr. Tawfik alluded to the spared nerve injury model here. We can see the creation of the sciatic nerve injury, as well as the placement of this bioresorbable system. And this can be stimulated by a radiofrequency coil. So there is no need for that connection between the battery source and the system itself. And when we look in animal models, just an hour of this radiofrequency stimulation through this system can actually improve recovery in the sciatic nerve. What we see is the EMG amplitude in the tibialis anterior muscle. With just 1 hour of peripheral nerve stimulation, you can see improvement in response. And if that is done continuously, an hour a day, over the course of 1 to 6 days, we see increasing increments in axonal recovery and better EMG response. Other ways that peripheral nerve stimulation is being used is also to restore sensory function. So peripheral nerve stimulation is actually being used to restore touch sensation to amputees with peripheral nerve damage. This can provide a bidirectional feedback. So not only can you control the prosthetic itself, but using peripheral nerve stimulation to give a realistic sense of touch sensation to the amputee themselves. So in the diagram on the right, you can see that this has actually been done, temporary implantation of peripheral nerve stimulation, say along median and ulnar nerves for about a month. This allows for control of not only the prosthetic, but also to regain sensory function. Peripheral nerve stimulation is also being used for hearing preservation. So stimulation of the cochlear spiral ganglia. Another application is it's very common for patients with varying degrees of hearing loss to have developed tinnitus. And so peripheral nerve stimulation is being used there. So now in that context of things, I just wanted to tell you all the different ways that peripheral nerve stimulation is being used, and I love it. And we are particularly interested in peripheral nerve stimulation for the treatment of neuropathic pain. So recently, this was a systematic review from 2021. I wanted to show you all the ways that peripheral nerve stimulation is currently being used, not just for the treatment of a mononeuropathy, but maybe CRPS, nerve entrapments, different headache indications, including cluster headaches, occipital neuralgia, and even pelvic pain. Among this data, you see there's only about 5 RCTs at that time. I'm going to talk about one that's been developed since then. But overall, the strongest evidence that we have, which is not great, is for the refractory peripheral nerve neuropathic pain. I'm just going to dive briefly into the mechanisms of peripheral nerve stimulation, just because I think this would be a little bit interesting from the perspective of an anesthesiologist. We can actually provide a temporary nerve blockade just with electricity alone, as you would with a local anesthetic block. And this we call a kilohertz frequency block. So this is charge balanced kilohertz stimulation. This can provide a rapid onset of complete nerve block with a modest carryover effect. So once you remove the stimulation, it takes maybe seconds to minutes for that nerve to start firing again. And what we see is that those myelinated A beta fibers, they're always a little bit easier to block, and it takes a little bit more to block the C fibers that we really want to target for pain control. But this is a non-selective blunt instrument block, and there are different systems being developed to deliver this type of peripheral nerve stimulation. What we normally think of with our modern percutaneous devices is actually sub-kilohertz peripheral nerve stimulation. And when we look in animal models, we can see that there is this older gate control theory. So the thought that we're always just stimulating A delta fibers, we're causing some sort of paresthesia and some sort of distraction. But I think these results are really interesting because it kind of goes against the gate control theory. And what we see is that there is differential blockade of C fibers and A delta fibers. And this is a little bit tricky. So lower frequencies like 10 to 50 hertz can actually target those C fibers that we want to target for pain. And then we also have the A delta fibers targeted at about 50 to 1000 hertz. But what's good news is that regardless of the type of C fiber that we're targeting, we get pretty good results with this sub-kilohertz peripheral nerve stimulation. So just giving you a little bit of background as to how this stuff can actually work. Now I'm going to provide you a little bit of a basis for our current ongoing project. So in terms of our clinical studies, we looked at a peripheral nerve stimulation percutaneously implanted device. It has an implantable pulse generator that's about the size of a dime. That whole system is placed into the body, just kind of like the animal model I showed you. And then there is a battery source that is external to the patient. So when they want to provide a therapy to themselves, they're going to put the battery on themselves to provide that peripheral nerve stimulation. So for the COMFORT trial, this was a multi-center RCT. We were examining the use of peripheral nerve stimulation combined with conventional medical management versus conventional medical management alone. I think one of the challenges with peripheral nerve stimulation is that the population is very heterogeneous in terms of the locations of pain, but this is just how it had to be kind of for the first iterations. We were treating pain in many different locations: low back, shoulder, knee, foot, and ankle. Our primary outcome was out at 3 months, and then there was a crossover for the patients who were randomized just to conventional medical management. It was a 2-to-1 randomization. We had about 60 patients in our active arm and 30 patients in our control arm. And if you're kind of curious where along the body we implanted for certain indications, for low back pain, we were targeting mostly the superior cluneal nerve. For knee pain, it was either the genicular or a combination of the perineal and sciatic nerves. The shoulder, commonly we would target suprascapular and axillary. And then for the foot and ankle, we have a variety of nerves there. In terms of conventional medical management, it was pretty much consistent across the board between groups. And so here I want to show you the outcomes. And so you can see that green line in the top figure. Both patient groups started around a 7 on their NRS scale, so kind of like in that moderate to severe range. And then starting at 1 to 3 months, you can see that there's a significant reduction in the NRS score and that it's sustained. And you're like, yeah, we hear this with a lot of pain devices. You're looking at the NRS. But the table on the right-hand side shows you that there was also clinically significant improvements in patient-reported outcomes. For example, when you look at the back depression inventory, you see almost like a 5-point decrease in that in patients who are not even clinically depressed. And there is still a concurrent reduction in depressive symptoms in the control group. But again, I'm going to show you that this story is sustained. So we continue to follow these patients up to 12 months, and we still see an 87% treatment response rate. And so our outcome is looking for at least a greater than or equal to 50% reduction in pain. You can see that that's continued to be sustained out to 12 months. And we are continuing to follow these patients over the course of 2 years, because I know that, if we're going to invest in placing a permanent implant, we want to see these kinds of sustained results. But you can see just a dramatic reduction in the pain scores over time. And again, looking at patient-reported outcomes, we see clinically significant improvements, not just in the pain intensity score, but also pain interference, back depression inventory, quality of life. And again, if we look at the averages, we still see like a 6-point reduction in their back depression inventory. And that's clinically significant. And that's not necessarily the case of what we see with patients who were in the control group. And so one thing that I want to emphasize is that even though we do some screening for severities of psychological distress before we place these devices, there may be some really significant positive psychological gains and other patient-reported outcomes gains that we want to explore. One of the things that we can see with both spinal cord stimulation and peripheral nerve stimulation is that the application of these therapies diminishes some aberrant responses in the central nervous system to pain. It diminishes both thermal and mechanical hyperalgesia and improves endogenous analgesia. Even with patients who have had these devices for years, say 5 to 10 years, and they come back, there is an acute unmasking of hyperalgesia and impaired condition pain modulation in the off state when the patients are tested with quantitative sensory testing. Another background that I'll give you on our research is our focus on sigma-1 receptor. So this is a transmembrane protein that is very highly concentrated in the central nervous system. And basically this density increases when there is a proliferation of Schwann cells and attraction of macrophages to an area of nerve injury. And what we postulate is that it improves our localization of peripheral sources of pain in the peripheral nervous system. And so I just want to show you as an example, this was an individual who actually had a painful nerve sheath tumor in the sciatic nerve. And you can see on the bottom right image that on that sigma-1 receptor radiotracer PET, you can see that it's lighting up. And this is not something that we would see in our day-to-day clinical practice, even with our MR neurography standards. In this particular patient, they had a non-painful sural nerve neuroma. So it was basically just a bump under the skin. And when you look under the sigma-1 receptor PET radiotracer, you see that it's not active at all. And so this is, one of our other biomarkers that we are exploring. I have a few more minutes. I just wanted to kind of put in a plug for our current study. So we're looking at mechanisms of stimulation for pain alleviation. We are using a combination of quantitative sensory testing longitudinally, as well as a PET CT, PET MRI using our sigma-1 receptor radiotracer. We're using the underlying infrastructure of the comfort study that I was telling you earlier. And we are following patients up to a year after surgery by doing these measures over time. And I just wanted to give a shout out to the big team of research coordinators, as well as faculty across different disciplines at Stanford, as well as our collaborators at University of Kansas. And hopefully I've opened your guys up to all the applications of peripheral nerve stimulation, not just in pain, but elsewhere. Thanks.
Perfect. Thanks, Jen. And rounding it out. Dr. Darnell.
Hi, everyone. So I'm Beth Darnell, and I'm a clinical psychologist scientist, and I'm going to talk about empowering pain relief. So I'm funded by PCORI and the NIH, and while I created the intervention Empowered Relief that I'm going to be discussing, I received no personal monies for this intervention. It's owned by Stanford University. I do have funding to investigate this intervention, and I'll be describing that research. So I'm going to start off by talking about pain relief after surgery and how we can best help people. This is Judy, and she's just had breast cancer surgery, and she's following her doctor's orders. She's taking her medications as prescribed, but there's something missing from her pain care plan. And what we're missing is that people can work directly with their central nervous system to gain relief. But what they need is the formula taught to them and to have that formula integrated into their surgical care plan and their medical care plan. This is a formula to stage them for optimal recovery. After all, surgery is just a controlled injury, and the brain registers injury and pain as a threat, something to be escaped. And healing after surgery really requires that we quell pain, so that we use a multimodal approach and apply this approach as early on after surgery so that we're staging people for recovery. A biopsychosocial approach to managing pain is low risk, there's no side effects, and it can be applied early on after surgery. And while this biopsychosocial approach is really taken as a given when we think about chronic pain treatment, we also need it for post-surgical pain management and acute pain management. So I created a 90-minute intervention. It's called Empowered Relief, and it teaches people how to calm their own central nervous system before and after surgery. And this includes simple skills in about 20 minutes daily so that people can train their nervous system towards relief. So their heart rate stays lower, their breathing rates stay lower, and it keeps mind and body in an optimal state of recovery after surgery. In our first published randomized controlled trial, we showed that women like Judy, who received Empowered Relief after breast cancer surgery, were able to cessate opioid use after their surgery more quickly than women who received a health education control. And we aren't the only ones in this space. We recently completed a scoping review of perioperative behavioral interventions, and we really trained our lens on those that provided extended analgesia. And so this published recently in RAPM, and of the 20 RCTs that we identified that had evidence for analgesia, we found 4 that were providing extended analgesia. So at least 1 month and all the way to 6 months of pain relief after surgery. These are 4 different types of approaches. And what we can see, these studies were all conducted in orthopedic trauma surgeries of some type. And here we included our trial that we conducted in orthopedic trauma surgery patients here at Stanford. And in this trial, we enrolled patients after orthopedic trauma surgery. We gave them an iPad in the hospital, and they received either Empowered Relief or their health control intervention, depending on what they were allocated to. And they got their intervention right there in the hospital, and then we followed them for 3 months later. And we found that the patients that were assigned to Empowered Relief had extended analgesia to 3 months later. Now, when we think about this, that people could just get something on an iPad in the hospital and that they could have some analgesic benefits that are durable, we begin to think about, the impact of this type of an approach. In 2019, the US Department of Health and Human Services identified Empowered Relief as a promising intervention that might scale pain relief after surgery. And we need more options like this. I will mention that Empowered Relief is the only of these 4 interventions that is in clinical use. Everything else is more investigative. And today, people receive Empowered Relief for surgery as standard care. It's spine surgery at Cleveland Clinic, at Cedars-Sinai, as well as orthopedic surgery in the NHS, and in various surgeries throughout the VA healthcare system. So brief pain relief skills for surgical recovery offers several advantages: quick access to care. My vision for the future is that all patients will be able to access this type of a low-risk, low-cost, scalable intervention either before or after surgery. They can receive it online in classes, or they can receive an interactive digital version. We could also envision that there could be a perioperative learning health system, and that we could integrate digital interventions into that learning health system so that then we can study people and the trajectory of their recovery, be able to identify who responds, who doesn't respond, et cetera. And this could become a standard part of the ERAS toolkit in pre-op clinics and integrated widely. So I'm going to shift gears briefly to chronic pain, and everyone's aware of the scope of the problem of pain. This was reviewed by my colleagues. But this is experienced by up to 1/3 of adults in the United States, ongoing pain. And the biopsychosocial treatment approach is really best practices. We integrate an approach where we equip people with the understanding of what they can do to best modulate their own experience of pain. And while this is typically delivered one-on-one or in groups with a trained therapist, we see that there's a lot of barriers to people receiving this approach, despite the fact that it's shown to be evidence-based and highly recommended. These are just some of the barriers preventing broad access to behavioral care. So one key solution is to look beyond traditional formats and what we can do to expand access. And this, again, is where this model of brief treatment for chronic pain, these brief pain relief skills, can make a measurable difference in terms of access and also efficacy. So this is where we've been applying empowered relief as a one-session intervention to rapidly equip individuals with these effective pain relief skills. So this is a 2-hour intervention. It's compressed, skills-based, so that over a single session, people learn about pain, what it is, what they can do to best manage it. People learn 3 core pain management skills, and then they tailor the information to themselves to create a personalized plan for how they will implement these skills in their daily life. It comes with a free binaural app for daily use, and large class sizes are possible because of its didactic format. So at Stanford, we can enroll and deliver empowered relief to 100 patients at a time, so that someone like Judy, even in the context of having moderate or severe pain, she can focus on what she can do to help herself on any given day. We have conducted 10 clinical trials on empowered relief, and I'm briefly going to provide the evidence for a couple of them. This first one was published in 2021, and this was a 3-arm randomized controlled trial where people were randomized either to 2 hours of health education with no skills, 2 hours of skills-based empowered relief, or 16 hours of cognitive behavioral therapy, which is considered the gold standard treatment. And we hypothesized non-inferiority between empowered relief and 8-session CBT 3 months post-treatment. And that is what we published. We found non-inferiority for reducing pain catastrophizing, pain interference, pain intensity, and a host of secondary outcomes, which you see listed here, which really telegraphed that we're seeing multidimensional benefits for a brief intervention. We next looked 6 months out, and we found durability of non-inferiority and clinically meaningful benefits 6 months later across a range of outcomes as well. We next studied empowered relief in chronic pain of any type, mixed etiology. This was led by Dr. Mesa Ziadny, and this was a randomized controlled trial where we found a similar pattern of results of multidimensional benefits that were clinically meaningful and superior to control. Because of this structured format of the intervention, it can be delivered by interprofessionals. So it's not just delivered by psychologists. We train and certify nurses, physical therapists, occupational therapists, physician assistants, physicians as well. And this is nice because we need to look beyond a single profession if we're going to scale this intervention. This was a nurse-delivered empowered relief, and this was a recent randomized controlled trial that was completed in 150 patients nationally, and they were followed, patients were followed 2 months post-treatment. And similar pattern of results, multidimensional benefits, 2 months post-treatment that were both statistically significant and clinically significant. This was our first study on this topic. And I just want to close out some of the evidence by talking about a new study that we did in people with Marfan syndrome. So Marfan is a rare, painful condition. It's a genetic disease, and it impacts the connective tissue in the body, and they have a lot of pain. We partnered with the Marfan Foundation, enrolled 108 people with Marfan and Marfan-related diseases, and we treated the entire cohort in one online class. They were treated en masse. Everyone just dialed in. They all got treated, and we followed them 3 months to see if they would benefit from the intervention. And the primary outcomes are on the right-hand side of the slide, the pain outcomes, which were all clinically significant. And then also we saw benefits for secondary outcomes, which you see on the left-hand side of the slide. And the ones that are bolded are the ones that achieved clinical meaningfulness. So we can begin to envision how we might partner with national organizations to really address the needs of underserved populations and populations that are understudied, so we can rapidly acquire evidence in these populations. In terms of dissemination and adoption, Empowered Relief is being delivered by 1,600 instructors in 30 countries and 8 languages. And we have tailored versions. I described the one for injury and surgery, but we have a tailored version for veterans and military personnel, one for correction settings that is being applied in the California prison system, and for youth. We are conducting this is an active national clinical trial, randomized controlled trial. We're studying Empowered Relief compared to 8-session CBT in 1,650 adults with mixed etiology chronic pain. This is a 6-site study, and we are studying both diverse and underrepresented populations. So that's some of the active research. There's others research, but in the interest of time, I'm just going to leave it at that. And just, again, just want to emphasize this idea that with these brief digital interventions, these could be integrated into a learning health system, both in the perioperative setting and also in the outpatient chronic pain setting, or even just naturally external to clinical care. But we truly have the capacity to address the needs at scale and provide pain relief broadly. So with that, I just want to say thank you for your time and attention. I'll turn it over to you, Sean, to moderate questions.
Why don't you stay here? Viv and Jen, why don't you join us up here? And let's open it up for questions. Javier.
I don't know if this was intentionally, but you know, I was listening to the last presenter and I was thinking about how there are some disease processes that are so maybe I posed this question. You envision central research and slide. What might that be? Given that some time.
Well, excuse me, I'll just mention that even though, you know, everything that we're doing with Empowered Relief is directly targeting pain, that this, you know, general calming of the central nervous system is really applicable across a variety of conditions. Some people are studying it in chronic fatigue, actually, but I think, you know, we could envision its applicability, like the foundational skills of it being, could be studied and applied across multiple medical conditions. It's not specific to pain, though pain is highly responsive to it.
Yeah, I can put in a little plug for things like vagal nerve stimulation. So actually, if we look at outcomes for other applications outside of pain, sometimes they're even better. We see vagal nerve stimulation, just a general increase in that parasympathetic tone and the calming of sympathetic. We see even clinical remission of like rheumatoid arthritis and colitis. And so we know that a lot of these neuromodulation therapies have applications outside of pain. Is kind of what is really interesting.
I mean, I can come up with, I was just not sure if there are other questions. I mean, you know, once you get down to the molecule, everything's sort of shared, right? So this is like, you know, obviously aging, just general processes of aging can be affected by targeting senescent cells. But also, like fibrosis, heart failure, atherosclerosis. So I think there's a lot. This field is just exploding. And I feel like every time I open my like blue sky, there's another senescence and something paper. So it really is an area I think that's going to cross a lot of different pathology. It's a bit like, the GLP-1 drugs now, like, they're originally for weight loss, but now we're finding they do all sorts of other things. And that's sort of related in that we think, all the excess weight is also an inflammatory phenotype. And so weight loss is also inflammation loss or inflammation control. And that's why it sort of seems, I think, to be helping a lot of other conditions, including maybe pain. So anyway, yeah, I think there's a lot of connection there.
Viv, you're doing great. We've got some questions that came in from the Zoom audience. So from Brees, awesome presentation, exciting work. Viv, what's the specificity for these senolytics to neurons? How do you foresee their potential for translation?
Yeah, it's such a good question, Bruce. So the specificity is not great for neurons. And that's why we're actually like all the next steps that we're doing is a lot of sequencing to really understand what is the profile of these P16 and P21 expressing neurons and what do they express that might be unique, that might track with the senescent phenotype so that we actually target that rather than P16 or P21 itself, because that is a shared molecule amongst all senescent cells. So what we don't want to do is go in, use a senolytic, and then, end up killing cells in the lung or elsewhere, but really be specific to the dorsal root ganglia. So there are ways to do that using, dosing, like intrathecal dosing, or, taking advantage of some of like the peripheral nerve work, even injections locally under ultrasound guidance, but really trying to understand the really detailed phenotype of those neurons is where we're going next.
And Viv, don't go anywhere because I'm going to just hit you up on the next one for you. From Troy Dildine, really great work, Dr. Tawfik. In human research, there's also been slow movement to look at biological age, incorporate stress, et cetera, compared to chronologic age. Curious if you believe there would be stronger relation between senescent marker presence with biologic compared to chronologic age.
Yeah, I mean, it's such a good question, Troy. So, I think it's probably more, when you're in the clinic, you see some patients who come in and they're 70 and they look 40, and some are 70 and they look 90. So I think, part of that is like what cellular stressors that person's been exposed to over time. So probably it's not really related to the actual age of the person, but their stress age. So somebody who's had, a lot of injuries, a lot of trauma, a smoker, for example. I mean, there's so much oxidative stress that comes with smoking, and all of those things can trigger senescence. So I think probably given that sort of underlying mechanism, it's probably more, I think probably somebody has lower inflammaging, to use kind of a popular term right now, is less likely to have senescence.
All right. Dr. Darnell, from Nicole McKenzie, there are empowered relief YouTube videos. Is there study of the effectiveness of this class of interventions?
So we have Empowered Relief isn't available on YouTube per se, but we have done multiple.
You didn't think it was available.
Yeah. But I mean, people would maybe get a part of it, but it's not really the full intervention, which involves class materials, et cetera, access to the app. We have done studies looking at the digital version of Empowered Relief, and those are the two surgical studies I mentioned. But we don't have any published research on digital versions in chronic pain.
Question number 2, Dr. Darnell. Pervez, thank you. Great talk by everyone. Beth, do you see a role for Empowered Relief for chronic pain prevention? Or is it more feasible for chronic pain treatment for a population like post-cesarean delivery who have a 15% prevalence of pain at 3 months following childbirth?
Yeah, thanks, Pervez. It's a great question. I think there's definitely a role for it in the prevention of pain, and we can apply it before surgery to improve post-surgical outcomes. We have not been powered, nor have we had the duration of time after surgery to be able to test whether or not it prevents chronic post-surgical pain. And in fact, there's no study of a behavioral intervention that has examined that. But we have shown that in essentially pain-free individuals prior to surgery, we can see benefits with post-surgical recovery, reduced use of analgesic medication. So I think there's every reason to believe that there could be benefits there.
Thank you. Jen, this one from Patty Clark, who many of you may not know, but was a faculty member in the pain division many years ago and has stayed on with the family. Jen, are bioabsorbable systems currently in clinical use in the USA? And if so, what's the cost of this system? And if I could just build on that, do you foresee a future where these bioabsorbable electrodes could be used in the perioperative environment, much like we think of bioabsorbable sutures, but here they're placed for a temporary peripheral nerve stimulation to provide perioperative pain relief?
Yeah, absolutely. I think that's a perfect application. All of this bioresorbable talk is mostly preclinical now, but we're not too far away where in the near future we'd be able to see that. We're also seeing kind of in that continuum that there are much more minimally invasive systems where it's almost the lead itself that is built for much easier explantation. So kind of the field of biotech in relation to neuromodulation is just exploding. And so what we talk about today might be even outdated in 5 to 10 years. I'm excited though. I want to see this stuff come into development.
Great. Questions from the audience, please.
Since I have the opportunity to plug the June 10th anesthesia research celebration, John Rogers, who is really at the forefront of the development of these bioresorbable systems, will be our guest speaker. So he'll be grand rounds and at the dinner, and we'd love to have you all there to learn more about this.
Great plug. Yes, Natalia.
So often the first question that we ask patients as they're waking up from anesthesia after their surgery is, are you having pain? And I wonder if there's a recommendation for another way that we can be sort of emerging people. In your research, have you looked at this and sort of how in that acute setting, we sort of sensitize people to the fact that they're having pain after surgery?
No, it's a great question. I don't think this is just my opinion because we haven't studied it. There's no data on it. I don't think there's a problem with asking the question. What's nice is if people could have options for how that pain would be addressed. So that it's not just, oh, you're having pain, let's dose you, but so that we can begin educating patients pre-surgically, preoperatively, provide them with information and skills so that they can have some agency over their experience. In fact, actually helping people have less anxiety as they go into the surgery, but then as they're coming out, it's not either or. We obviously need the medications, we need all of these options, but it's such a unique opportunity to empower the patient essentially so that they can be an active participant in their pain management beginning right after the surgery.
I'm just going to put in an additional plug that there's certain demand characteristics when that first question is, do you have pain? Because it focuses attention on that thing. Then we ask them an intensity number, which often has really rather little value in many of these patients' lives. And the problem is one pain score is not another person's pain score. So perhaps finding ways of asking the question that are less focusing and asking them to what extent is it actually bothering them. And we validated some instruments that around pain bothersomeness that have been very effective in that role. Other questions here from the audience? Yeah.
Hey. Great talks. Thanks for having us together. Thematically is great. My question's for Jennifer. How do you, for the peripheral nerve stimulation trials, how do you do your control?
Yeah, it's a little bit messy, you know, I mean, it's clinical trials, not mice. So we allow for conventional medical management. There are a few things that we have tighter control on, like radio frequency, nerve treatments, and obviously other neuromodulation techniques are off the table. But it's a bit of a challenge, you know, at doing any kind of device trial because it's kind of an end treatment and not an early treatment. So it's not like you're getting the numbers in terms of, compared to medications and whatnot. So it's a little bit messy, we're just trying to tease everything apart, but we're keeping track of all the things.
So I assume that patients in the active arm know they're in the active arm. There's, right?
Yes.
They're not blinded. So
Yeah.
have you explored ways around, better masking, some intervention that is not effective, but the patients wouldn't know?
Yeah, it's tough to, you could maybe think about implanting a device that's inert, but there's obviously some ethical challenges there. You can do some clinical trials do a sham stimulation, but again, then there's a question, with that proximity to the nerve, if you're actually providing sham or if you're providing some degree of therapy. So it's a challenge. I'm sure, it's a critique of a lot of these trials. But it's something that we have to kind of tease apart. These treatments work pretty well for certain patients and for a sustained period of time. We did look observationally at our own patients at Stanford, and we see even for 60-day PNS therapy that they have pain relief even like 2 years out. And so we want to figure out why that works that way and improve the therapy for the majority of patients who get it.